Here, and we're getting ready to start our second surgery of the day and our last for today. Our patient is having back pain in the L4-5 region on the left side. There's a herniated disc, it's small, but there's an annular tear, and our goal here is to go in and repair that disc to get rid of the back pain. Okay, are you comfortable? We're going to get started, okay? So you're going to feel a little stick and burn?
Yes.
Do we put some in?
Yep.
Okay. If you're having any pain, just let me know. Just say ouch, all right? And I'll go ahead and stop and adjust what I'm doing. Don't try to move though, okay? All right. You're going to feel a little stick and burn right now. Let me just palpate real quick. Okay. That's just my finger you're feeling. You feel any burning? Huh?
Yep.
All right. Sorry about that. Okay. We injected about 5 cc's. We're going to get started, okay? Remember, if you feel discomfort, just let me know. Say ouch, and I'll take care of it for you, okay? Now we have Lido and Marcaine, right?
Correct.
Yeah, sorry about that. Is that uncomfortable for you? That's just some medicine I'm putting in. Give it a minute to work. Shot. Shot.
Back. Five.
Shot. Shot. Lateral. How are you doing?
All right.
Are you pulsing?
Yes, sir.
Okay. Shot. All right. Let's move this just a little bit. You should be draping right above a little bit above the crack, right?
Yes, sir. Yes, sir. Do you think it's
I think you draped higher than normal. Two more cc's of local. Everything's fine. Shot.
Thank you very much.
Shot. 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 Sorry about that. Is that uncomfortable? Shot? 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 All right. Shot? Let's go AP. Are you okay? Everything's going well. You have the MRI up? Yep. Go ahead and scroll the MRI for me. Perfect. Lateral. Scroll it. Keep going. Yeah, the other way. Keep going. Keep going. That's good. Okay. Let me go back to the midline on that MRI. Back to the midline on the MRI. Stop. That's good. So there's a pseudo disc. I can see it on the x-ray. Then there's the 5-1. Then there's the 4-5. And we are at the 4-5. Everybody agree?
I agree, sir. Yes, sir.
I would want to get your opinion normally, but you can't see it. Are you laughing down there? All right. Any discomfort? Huh? Yeah, I can see the bulge. You can actually see it on the x-ray. You know you've got a good x-ray machine where you can see disc herniations on it. Are you comfortable? You feel anything? Huh? What does it feel like? Is that your normal pain? Saying yes?
Yes.
How bad was that on a scale of 1 to 10?
8. He said 8.
That's the most calm 8 out of 10 I've ever seen. So, that's your typical pain, right? Well, when you wake up, it should be gone. You've got a pretty big tear. You'll see it on the films afterwards, but it's impressive. It's a grade 4, easy. When you wake up, we'll be done. Can you count from 1 to 100 out loud? You're doing great. You're going to feel a little burning in your arm. That's normal. Shot. 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 All right, so we're in the right bit disc and we're on the correct side. And this patient's preoperative MRI to me was not that impressive. If 99% of spine surgeons would look at it and say, there's nothing wrong. But we just tested this disc and it created his typical daily pain that he's always having. So it's just another example. You can't trust MRIs to tell you where pain comes from. You have to trust your physical exam and your experience, and you have to look at the MRI and any additional testing you have and really put it all together. But it's an art, and truly it is an art. I would say that 100%. There's no way to use specific objective criteria every time to be able to tell you whether a treatment is going to be successful for that patient. But when you combine the localization of the pain on exam, you combine the fact that other areas like facet joints are not the source of the pain, you combine your experience and obviously imaging like MRIs, then you can make the right decision for the patient about 98% of the time. In this case, like I said, I was concerned that maybe this disc, being such a small herniation, wasn't going to cause this patient pain. But I just tested the disc, and indeed it reproduced his daily pain up to an 8 out of 10. Also, the tear that I'm seeing is pretty massive. That's a massive tear. That's a huge, huge tear, and the MRI missed it. I mean, there's a tiny little area on the MRI that shows what's called the high intensity zone with like a millimeter bulge. But I'm telling you, if this patient had gone anywhere else, they would have been blown off like many of our patients are and told there's nothing wrong, there's nothing that can be fixed, when in reality they have a fixable problem. So again, don't settle for living in pain. Go find someone who can figure out where your pain's coming from and fix it for you, because the pain's real, and doctors will blow you off and tell you there's nothing wrong. Other people will tell you there's nothing wrong, but there really is. Is he taking any herbal supplements? Because and our blood pressure is perfect.
The blood pressure
Yeah.
this time compared to the first time, he was very hypertensive. But this time he's good.
Shot. Well, we're going right into the tear. You can actually see the guide wire passing right through the tear. And of course, here comes the dilator entering the foramen. We're passing just below his left L4 nerve root, just lateral to the left L5 nerve root. This patient's not having any leg symptoms currently. And shot. Really what they're suffering from is back pain. And honestly, the MRI really understates the problem tremendously. I mean, there's a huge tear here, and I couldn't even see that on the MRI myself. And I've looked at literally tens of thousands of discs, spinal discs on MRI, more than pretty much anybody. And even I could not appreciate how the severity of this injury based on MRI. But I believe the patient, what they were telling me, and they localized the pain right to L4-5, left side. So I saw there was an abnormality. I saw the patient's pain localized to that area. And I went ahead with what I believed was the right treatment. And actually the patient helped because they wanted this treatment. They wanted the Duke laser disc repair. Like all of our patients can go anywhere in the world they want. They're not forced to come here. And for many of them, they have to pay a lot of money to come here. So they choose to come here on their own for reasons. And I would say the reasons are they want the best care and the best outcome. So, shot. This patient in particular knows what's available all around the world. This patient is, like a few of our patients, a professional in medicine and treats pain themselves every day in patients. This patient chose Duke Spine Institute for their care for a reason. Shot. All right, that's good. We've got our working channel in position. I'm taking the dilator out. So far, we've lost a few drops of blood. Our blood pressure is perfect. And when I say ours, I mean the patient's, obviously. You can see the tube is right through the tear, which is exactly what we want. We're not causing any further damage to this patient's disc or spine in any way. We're literally going through the damaged part that's already there. So by going through the damaged part of the disc to fix the disc, we don't cause any additional collateral damage. Every other spine surgery in the world will cause additional damage to the patient's spine in order to fix the disc, but not the Duke laser disc repair.
Strap on, please.
All right. Well, down the rabbit hole. So we're inside the disc herniation right now, and I'm going to try to grab any loose fragments of herniation out. Normally I don't get very much. I have to use the laser to release the fragments. There's a big tear right there. So we're going to bring the laser in. Laser on 30. You can see the glass fiber. The glass fiber of the laser, for those of you wondering, is 1/2 millimeter wide. Look at that disc. It's just zapping away nicely. So the more scarred up a disc herniation is, the slower it zaps away. The fresher the disc herniation is, the faster it zaps away. If you have a brand new herniation, like that's only a few weeks old, it'll melt like butter with the laser. The older herniations are much more scarred up and collagenized. In other words, the inflammatory system of the body is working on that herniation, trying to destroy it. So it's attacking, and it destroys a little bit of the nuclear material, but then it replaces it with scar tissue. So the inflammatory process of the human body is quite amazing. It involves several cell types, and it involves cells that are highly specialized with functions. One of those cells, for example, is a macrophage. Another is a polymorphonucleosite, or PMN, aka a type of leukocyte or white blood cell. A neutrophil, basically. And then there are fibroblasts. There are new nerve fibers that grow in. And there are blood vessels, endothelial cells, and there are stem cells. So there's a variety of cell types that are involved in inflammation, and it's inflammation that causes the patient's pain in their back and down the leg when they have it. So over time, the polymorphonucleosites that enter this zone of inflammation are releasing their enzymes that are located inside the cell within vacuoles called lysosomes. And inside those lysosomes, you have these enzymes that once released, they go out and destroy proteins and lipids. They're basically the way the body deals with foreign tissue or foreign bodies. The way your human body deals with them is it mounts an inflammatory response. So there are two hematopoietic defense systems. You have your lymphocytic system with lymphocytes, which is immunological, and you have your inflammatory system, which is not immunological. The inflammatory system is pretty much indiscriminate, and it's what your body uses to attack things like splinters or bacteria. Your immunological system is also used to attack bacteria and viruses, or tissues that have receptors on their cell surfaces that elicit an immunological response. And that's a complicated response I'm not going to go into, but it involves B cells and T cells and antibodies, and that's not what's happening here. What happens with a herniated disc is an inflammatory response, not an immunological response. This is not tissue rejection, like you think about somebody rejecting a lung transplant or a heart transplant. This is inflammatory, not immunological, once again. And so the main cells that are involved in inflammatory are polymorphonucleocytes, aka neutrophils, and macrophages, and fibroblasts. So what happens is this herniation, the herniated nucleus, pops out through the annular tear, and it's seen by your vascular system as a foreign body. So the vascular system becomes very leaky. The endothelial cells that line the blood insider layer of the blood vessels, capillaries, become leaky, and they start to exude plasma, and they start to allow margination of white blood cells in that area, and then the white blood cells pass through the endothelial wall barrier into the interstitial tissue or surrounding tissue. Those cells are macrophages, PMNs, mast cells, and they actually start to attack whatever's there indiscriminately. So they will attack not just the nuclear material that's there, but they'll attack any tissue. Even normal tissue gets caught up in the spray, friendly fire, so to speak. And this inflammatory process goes on as long as it takes to get rid of the foreign body. Well, when you're talking about a herniated disc, that nuclear material that's the foreign body, it's very big, and it takes a long time to get rid of it and wall it off. And so that's why back pain happens for so long with a herniated disc, is that the inflammatory system is fighting day in and day out. And every time it makes some progress and it removes some of that nuclear material, you stand up and walk or bend or exercise, and it pushes out a little bit more. By pushing out a little bit more, you reinvigorate the inflammatory process. The inflammatory process doesn't have a brain. It's all done, subconsciously without your brain controlling it. So these are very primitive cellular responses. These cells respond to inflammatory mediators, otherwise known as cytokines and interleukins. And these inflammatory mediators are released locally in the area of inflammation, and they promote more inflammation. So this process of inflammation upon inflammation upon inflammation goes on until the nucleus or the interposed disc material is gone, which takes a long time. That's why people have chronic back pain with a herniation. Now, who understands this? I do. Dr. Santiago does now, because he trained with us. He understands this process. But 99.9% of doctors don't, which is why they can't fix your problem, because they don't understand the basis of it. That's why we broadcast live surgeries, so that I can explain this to you all so everyone else can understand. Believe me, I be teaching doctors too, and I've done that. I've gone to meetings of the American Association of Neurological Surgeons as an invited speaker. I've published my research with them. I've shown them the technique. I've done videos and lectures, and I've talked to neurosurgeons from around the world, orthopedic surgeons from around the world. I've spoken at North American Spine Society. I've spoken at the AANS, the CNS, at ISAS, which is the Society for the Advancement of Spine Surgery. I've even lectured at Dr. Young, who originally taught me some of my endoscopic techniques. I've been a guest lecturer for him for cervical spine. So I've taught these surgeons all over the world at lectures, and yet they still don't get it. Mostly because they're too busy treating other conditions. They haven't really focused on it. But what Duke Spine does is we focus on spine problems. We don't deal with brain problems, really. We don't deal with other issues that other doctors deal with. Our focus is on spine. We're what's called a focus factory. And because of that, we do it really, really well. Anyway, we're just about done. I need about 2 minutes, and I'll be done. And this was not a huge herniation. It was a big tear, but not a huge herniation. They're pretty much done. Yeah. So the question was from our audience, if I remove the granulation tissue from the annular tear, what happens? How does it heal itself? It heals itself by the second and third phases of inflammation. which is fibroblasts grow in, and they start laying down collagen and elastin and connective tissue. And that collagen basically seals off the hole. And it takes about 6 months for it to be laid down, and it takes a full year for it to mature. So for a scar to mature and contract and form covalent bonds between the fibers and become strong once again, it takes a whole year. So if you understand the inflammatory process, you can understand herniated discs and how they cause pain. Standby laser. I think that's it. I don't see anything else. I think it looks good. I'll just do a quick reach in and grab and see if I can get anything else out, but uh, 1 minute. Where's the pedal?
We have a question.
We have a question. Go ahead.
One of our viewers is wondering, what kind of pre-surgical requirements do you have for patients, and are there any medications they need to be put on?
So what kind of pre-surgical requirements do you have for patients? Are there any medications that they need to be put on? The answer is no, no medications at all. The only thing I require is that the patient see me either over the internet through a Skype call, and that I see their MRI, CAT scan. Usually MRI, CAT scan is all we need. And that's it. So a consultation and an MRI. A current MRI, I should say. Not an old one, but a current one within 6 months. That's all. Just that simple. And then we can determine what's wrong and what needs to be done to fix it. We're done. Surgery is over. I'll show you the incision. It's tiny. I'm taking the tube out. Can you all see this?
Yes, we can.
So this is how we do the surgery right here. This is a scope and camera. And I'll just show you what I got. So this part is the camera. You can actually even disconnect it from the scope and see it. This is the camera. And that's a high definition camera. Special. Here's the light source for the scope. It produces a very powerful illumination that goes down through fibers. Here's the irrigation source. It's a IV right here. And there's the scope itself. So pretty neat stuff. I'm applying a little bit of pressure to the paraspinous muscles, but here's the incision right here, folks. You see that? The entire disc herniation was repaired with this 7mm incision. And this patient will be able to go home usually about 30 minutes to an hour after their surgery. So I'll come to the conference room and answer some more questions. If you have them, go ahead and type them up. I'll be happy to answer them for you. This has been a Duke laser disc repair, left L45, for a herniated disc that was causing back pain. EBL is 2 mil. This is DLDR, left L45, and you're going to do bilateral rhizotomy, L2S1. All right.